Welcome to another episode of Doctor, the award-winning radio show and podcast featuring your physician host, Dr. Tom McGovern.
And I'm Dr. Chris Stroud, and this is the show where we discuss relevant health-related topics and always from an authentically Catholic perspective. We're brought to you, Doctor, that is, by the generous underwriting of our friends at CMF Curo. You can learn more at mycatholichealthcare.org. You can live your Catholic faith in your healthcare with CMF Curo.
Joining us tonight and today, and whenever you're listening to this on the EWTN Global Catholic Radio Network, will be a first-time guest, Dr. Tom Bouchard from up north in Canada. Dr. Bouchard is a family medicine physician who does low-risk OB, and we are once again going where angels fear to thread. No, that's not it. Where they fear to tread. Yes. Threading is something that seamstresses and tailors do. Anyway, we're going where angels fear to tread because we're going to have three men talking about natural family planning and breastfeeding. Yes, roll your eyes. Please do it. But Dr. Bouchard is a researcher, does basic research in natural family planning and breastfeeding and how they're related to each other. So we're going to talk about that. And so let's start with a softball question to our resident doctor obstetrician. What makes this topic of any possible interest to our listeners, Chris?
Well, hopefully we've got a lot of listeners, for one, but hopefully of that big collection of listeners, we've got a lot of faithful Catholics that are not contracepting, or as they're approaching that question, they don't want to contracept. And, leading up to this point, and this point meaning maybe the last 5 to 7 years, and Dr. Bouchard will help us understand that, it could be a little scary thinking about it. But the NFP world today is not your parents' NFP world. And, the key is, you mentioned the word in your intro, Tom, research. And that's what we're going to learn about the science behind NFP, which is the power now behind NFP. There's so many methods, whether it's the Marquette method or the couples to couples symptothermic method or the Creighton fertility method, or, it just goes on and on. They're all tremendous. They're all good for a certain group of people. And today, they're all based in science and research. And so, in answer to your question, why pay attention? Because now, more so I think than any other time, you don't have to go against your beliefs and church teaching if you have decided you want to avoid pregnancy. A married man and woman can avoid pregnancy without mutilating their bodies, tying their tubes, or having a vasectomy, or without taking harmful hormones and without contracepting. So you don't have to either be pregnant or not be intimate. A couple can be intimate, use NFP, and not become pregnant. And relatively easily, they can accomplish that goal thanks to some of the work and the research that we're going to hear about tonight.
So, Chris, one word, mucus. Yeah, let it sink in. So we're going to be talking about mucus tonight and not the kind above the neck. So what is the role of cervical mucus and how is it affected by the hormones of a woman's cycle?
Tom, this is like me asking you about skin moles. This is my favorite topic in the world, right? Cervical mucus. But it is so absolutely essential. So there's two kinds of mucus. One is estrogen-based. The other is progesterone-based. And the estrogen-based mucus is the special fertile mucus. It only exists for a short period of time. And our Creator has designed this mucus that lines up in these nifty little tracks that are the perfect dimension to allow a sperm to swim through. And then as soon as progesterone comes after ovulation, those beautiful little escalators of mucus suddenly flip into a grid that doesn't allow mucus through.
Oh, into waffles.
Right. It is exactly. It's a biological valve that opens and then it rapidly closes. But mucus is the key for fertility, not only for what it does, but for what it represents. So low mucus could mean low estrogen. Well, that could be a follicle that's not working up to snuff, not a very good follicle. But also the body needs the mucus to transport the sperm from the vagina up into the cervix, up into the uterus. So mucus is the key, one of the key things of the fertility cycle.
Very good.
It doesn't get better than that, does it?
Uh, what can I say to that? Um, so in one of our guests' publications in the scientific literature, he has this paragraph, and I'm curious on your take on it. It says at the end of a career developing oral contraceptive pills, the researcher Carl Gerasi wrote about the importance of research in NFP. He suggests that the measurement of urinary hormones at home could lead to a jet age in the understanding of a woman's fertility, saying that the determination of when she is ovulating should be a routine item of personal health information to which she is entitled. What do you think? The developer of the original pill said that. What does that mean to you, Chris?
It is remarkable. I mean, we'd have to ask him, but I think what he is saying, either intentionally or unintentionally, is if we could figure out this progesterone test, we wouldn't need oral contraceptives. Because in the body, in the woman's reproductive cycle, progesterone only appears after ovulation. Another way to say that is once progesterone has appeared, it means ovulation is over, and that means the opportunity for pregnancy is over until after the next menstrual period. So, to the extent that we could quickly and inexpensively and reliably test progesterone at home, like a urine pregnancy test, once we can do that and be confident in it, it really is a game changer for couples that need that reassurance to say, from this point until menses, we are safe, so to speak, from pregnancy if that's what we want to do.
Wow. And final question. What do you most hope to learn from our guest today, Chris?
Well, I think I and listeners, what we really need to know is if you think about it, for the average couple that is doing just fine, any of the NFP methods generally work well. And their temperament and their lifestyle may make one method a little better than the other. Now, if they're having an infertility problem, one method might be better. But for the average couple, really any method is generally good. But there are two really tough periods of time in a couple's life. And that is right after a baby, when the woman is breastfeeding and they want to avoid pregnancy. That can wreak havoc on the cervical mucus, and it can wreak havoc on a young couple trying to figure this out. The other one is at the other end, kind of the reproductive lifespan. That's the perimenopausal woman who is thinking it would not be funny at 48 for me to be pregnant. I don't want that. How do I use NFP to trust and avoid that? Well, those are the two areas where a lot of NFP methods here to date have really let couples down, in my opinion. And so I hope and I think that he's going to share with us some really great information to try to work on those two specialty areas.
Well, we'll listen for that right after the medical trivia question of the day. Today's category, what else?
Cervical mucus.
Mucus. That's right. We got it. This is Chris's happy place. All right. So, monitoring cervical mucus, as you know, is a part of most forms of NFP. At times, it can be more thin or more thick. It changes. So, the question is, what is the primary ingredient in cervical mucus? That's it. What's the primary ingredient? We'll have it for you at the end of the show, but right after this break on Dr. Doctor, we'll have Dr. Tom Bouchard on breastfeeding, NFP, etc. We're back now on screen, for those of you watching, with Dr. Thomas Bouchard. Thomas finished his undergraduate degree in Canada at McGill University, and then did 3 years of Parkinson's dementia research up in the University of Alberta. But then he did his family medicine residency after completing medical school at the University of Calgary. He now practices general family medicine as well as low risk OB. He's delivered about 500 babies over the last 10 years, and he's in charge of geriatric care at a couple nursing homes. But he's got a special interest in fertility medicine, and he's a consultant for the Institute of Natural Family Planning at Marquette University south of his border in Milwaukee, Wisconsin. He's a lecturer and perinatal palliative care committee member at University of Calgary. He's published widely. His most recent initiative is developing an online platform for his own patients and for fertility consults. And he was a recipient 8 years ago of the Lineker Quarterly Research Award. That's the journal that the Catholic Medical Association publishes. Thomas, welcome to Dr. Doctor.
Thank you for having me.
So, dementia research to fertility research. What happened?
So, well, I was always fascinated from my high school days in neurology
Oh,
and neurosurgery, and then the life-changing event for me was attending the first birth. So, as a medical
Mm,
student, when I saw the first delivery, I was so awestruck by the drama of the delivery room that I knew I had to do something with babies, and I couldn't give up the babies or hand them off to somebody else. So I said, the only way I could do this is in family medicine.
wow.
So that was the first romance with family medicine through delivering babies. And then I did an elective in med school with an OBGYN who was using just off label the Clear Blue fertility monitor in a reverse way. Instead of trying to achieve pregnancy, he used it with couples. He just kind of invented his own protocol to use it for avoiding pregnancy.
mm,
So he and I wrote a paper when I was a medical student. And in the process of writing that paper, I discovered that the same thing was happening at Marquette University with these nurses who invented the Marquette method. So it was happening in parallel, and they both came up with the same idea. One guy from Canada, this group of nurses from Marquette. And
Got it.
so I that started my kind of correspondence with Richard Faring and Mary Schneider at
Mhm.
Marquette, and I've been working with them ever since I joined them for a conference in 2012. They were very gracious to kind of let me weigh in on some of their protocols.
Before we get into the really important stuff, I think a lot of listeners probably you're the only Canadian they maybe have ever talked to, and we hear a lot about the Canadian health system. But you, a trusted resource, tell us maybe some of the differences between our two health systems.
Yeah, I think the biggest thing, and this relates to fertility consults, is because it's a single payer system. I'm able to see people for NFP consults regardless of their circumstances. So
Mm,
I don't have to ask about insurance or anything else. I can do NFP consults and use any general family planning practice code, and I can get paid for it, right? So there's no question. Anybody can come and see me. They can self-refer, be referred by a doctor. Anybody can see me for NFP, which is great.
sure.
The big drawback is efficiency and wait time. So you may have heard in Ontario, in the province of Ontario, cold and flu season is backing up their hospital system. So that is a major drawback, the efficiency and wait times, whereas universality is kind of the major advantage.
Mm. Is it similar to maybe the British system? Do some people have insurance, private type insurance that they might use for things that the single payer state system doesn't cover?
No, there's
No.
nothing like that. In fact, it's illegal to access private pay care. And so people will cross provinces and they will pay for a surgery in another province because in their own province, it's illegal to pay for that procedure.
Interesting. Wow.
Oh,
Well,
but in
thank you
other
for that.
provinces, you can pay.
That's right. It's a loophole.
Wow.
Bizarre. All right.
Hmm.
So let's go full force into this NFP thing. So, one of the most challenging times to use it is after giving birth, before the regular menses start again, especially women who are breastfeeding. So, how often do women actually ovulate before their first period after giving birth?
So overall, it's about two-thirds of women who will have ovulation before their first period, which is why it's important that women understand in general that there's a high chance of ovulating before their first period. So not just to wait for that first period to think about whether they're fertile. And that number goes up the further postpartum they are. So when you get past 12 months postpartum, well, 90% of women are going to ovulate before their first period. The average return of fertility is between 6 and 8 months, and that's because of the introduction of solids and suckling decreases.
So, I understand it's easier to figure out when that first ovulation is if a woman is bottle feeding their baby instead of breastfeeding. Is that right? And if so, why?
Yeah, so the bottle feeding difference, if it's formula or express breast milk, the biggest thing is after the prolactin effects in the early postpartum period are no longer as relevant. The next biggest thing to suppress pituitary hormone activity is suckling. So more suckling happens, the more FSH and LH have less effect on the ovary. So suckling is the major driver of that delayed return of fertility.
Do you think, or is there evidence for in third world countries where food is more scarce for the babies that women may exclusively breastfeed longer? Is breastfeeding more protective in those settings because of just what you said, the suckling?
Yeah, for sure. So exclusive breastfeeding for longer periods does delay the return of fertility longer. So
Mm.
in a lot of poor countries, the use of exclusive breastfeeding, or another term for it is ecological breastfeeding, often delays the return of periods. And there has been some studies showing the differences in different countries in that regard.
Wow. Now, speaking of studies, way back before the pandemic hit in 2018, you and some of your colleagues published a study about this relationship between mucus and hormones in breastfeeding women. What were you going for in that study, and what did you learn?
Yeah, the driver of this was and this was the topic of the Edmund Pellegrino Award that we worked on together. This study looked at cervical mucus to urinary hormone levels in breastfeeding women, and we were wanting to ask the question: is it true that mucus can be confusing in the breastfeeding time? Because we had lots of anecdotal evidence from women saying it's very hard to discern mucus during the breastfeeding period. So, because of that challenge, we wanted to look at the urine hormone levels. And the what we found was that the mucus was not correlated with the underlying urine hormone levels about 2/3 of the time. So
So
that means
Thomas,
it's
why do hormones end up in the urine? How are they trustworthy versus hormones in the blood?
Very good question. So, hormones in the urine are excreted through the kidneys, and the hormones in the urine are concentrated by the kidneys. So, because of that concentrating action, in some sense, the urine is a better reflection of hormones over time than a spot
Oh,
serum value.
oh, very good. And what hormones are you looking at in the urine?
So in this particular study, they were looking at estrogen and progesterone. In the some of our more recent studies, like the Clear Blue monitor does estrogen and LH, and the newer monitors, which we can get into later, they look at FSH, LH, estrogen, and progesterone.
Oh my goodness. So when you say they didn't correlate with the mucus, do they normally correlate when you're cycling, when a woman is
Yeah,
cycling?
and
So what was
that's
different here? What didn't correlate?
so in a woman in regular cycles. This is why Billings and Creighton and symptothermal methods that have mucus as their base, they work well in regular cycles because mucus is responsive to estrogen. So as estrogen goes up, there are very particular changes that lead mucus to having this peak quality that we would say. So clear, slippery, and stretchy is some wording that could be used to describe this. And women can sense this naturally. And if you ask them, they can learn to discern that mucus change over time. But in the breastfeeding period, because of the effects on the pituitary and the dampening of FSH and LH effects on the ovary, the same mucus effects and sensitivity to estrogen don't produce the same mucus changes as what we would expect in regular cycles.
You know, it's probably obvious to some of our listeners and maybe not to others, but the reason we're talking about this is, if you think it through from a very practical standpoint, you have a couple, they've had a baby, they don't want to be pregnant right away, probably. They're breastfeeding and they want to use NFP.
Yeah.
And so they can feel completely lost. Do I either risk it and become pregnant, or do we avoid intimacy for the next, year?
Yeah.
Um, Arguably, that's probably not the greatest thing for marriages, but it's a terrible dilemma. So
Yeah.
all of this that you're talking about, listeners, it's not just for some academic, exercise. It's very, very practical because this is such a challenge for couples.
Yeah, it's true. And the idea of couples abstaining for months and months and months can lead to frustration and challenges with the couple. So I feel obliged to help couples get back to their life of intimacy because it brings back the warmth in the home, as one saint once put it.
A saint
Or
said that.
as the church
Yeah.
teaches, intimacies for both babies and bonding, not one
Yeah,
over the other.
that's right.
Very good. So uh, now some methods use basal body temperature. Is that of no benefit here? Does this add to the confusing mucus?
It does. So basal body temperature increases after ovulation. But remember, we're waiting for that one
First.
ovulation before the first period. So that's going to be a long time before it's beneficial. So when it comes to temperature, the other thing is there could be disturbances. So a woman waking up multiple times a night to breastfeed her baby is a type of disturbance that makes it not
Mm,
a valid measurement the following morning.
I said in our introduction before you joined us that at least in my mind, what's different today about NFP and maybe in our parents' or grandparents' generation is really um, the science, the research. It's no longer something that should get eye rolls from professionals because this is science based, it's evidence based, it's
Yeah.
research based. But what are some of the technologies you referenced? A particular kind of monitor. Walk us through some of the technologies that are making NFP better and easier to use today.
Yeah, so the Clear Blue monitor I mentioned before really was a game changer for the postpartum period. And in fact, 60% of people who use the Marquette method are breastfeeding folks.
Mm.
What they do is they realize probably after baby number two that, oh, this didn't work. So most users come with baby, wanting to delay timing with baby number three, and they come to the Marquette method because last time the mucus didn't work. That's a common story.
so what
And
is the
so
Marquette method? Okay. You guys may know what it is. I haven't got a clue as to
I'll
what it
tell
is.
you. So Marquette was developed by some nurses at Marquette University, and these nurses were initially working with the Creighton method, and what they realized was that they needed additional tools, and because those tools weren't easily fit into the standardized approach that Creighton used, they decided to do a spin-off, creating this new method called the Marquette method, which has as its base the use of a urine fertility monitor.
Oh.
So the Clear Blue monitor tests for estrogen and LH in the urine, and so women will do a dipstick test in the morning that they plug into a monitor. And this monitor actually gives a low, high, or peak value. High meaning estrogen has gone up, and peak meaning LH has surged. So the monitor gives this objective sign of hormones in the urine, and it gives more, you could say, reliable testing to give to people who are wanting something more objective rather than just a subjective sign in the mucus.
And I think it's fair to say too, it's a proactive piece of evidence. The
Yeah,
basal body temperature shift is driving down the interstate, looking in the rearview mirror.
that's right.
It's already happened.
Yeah,
But the Marquette method allows you a forward looking, something is about to happen.
that's right.
Beware.
That's right.
Now, in the
Exactly.
interest of transparency, we don't have a relationship with the maker of Clear Blue. That's just a brand.
Yeah.
Um, but are there competitors in the market space for that monitor, or is that the only company producing it?
Yeah, so there's a whole bunch of LH test strips, really cheap dollar store type test sticks you can get for LH, which will predict ovulation within a few days. But those cheaper test sticks don't have the estrogen assay.
Right.
So Clear Blue has been the market leader in this area for about 20 to 25 years. But in the last few years, there are some new quantitative monitors. And one of them is the main focus of my PhD research, which is the Mira monitor. And the Mira monitor also has test sticks, but these test sticks, instead of giving low, high, and peak, they give actual values of the hormones. So that's going to be a game changer when people can actually see those hormonal curves in real time, day to day. It's going to really revolutionize how we use this for NFP.
And when you say that, I'm assuming that you mean it's going to make this task easier and more reliable. So the couple can really trust the data and be very specific about when to be intimate or when not to be intimate, depending
Yeah,
on if they want to achieve or avoid.
yeah, exactly right. And the challenge when you're looking at data is user friendliness, and both these monitors are user friendly. But the other thing is simplicity of use. So Marquette translated using the Clear Blue monitor into some simple instructions for the method. When you get more data, like numbers, then you get run into the challenge of complexity. How do we turn that complexity into something more simplified? And so, what our goal is going to be over the next few years is starting to recruit people for research studies to say, let's create an algorithm for NFP using this new quantitative monitor so that instead of having this complex data set that we leave to women to interpret, we want to give them the tools and thresholds that will help them plan accordingly.
So, how
Now,
did your 2021 study address these two different monitors, Thomas?
So that study, we basically compared Clear Blue and Mira side by side. And we said, let's use the thing that we know well, the Clear Blue monitor, and let's compare it to the thing that's new. And so what we showed in that 2021 study was that Mira and Clear Blue agreed really well. But Mira did pick up on some sub-threshold peak levels where some women have lower LH values that wouldn't go past the threshold for Clear Blue to give a peak, but it still gave you a number. So that woman with the sub-threshold values, we were able to say, oh, look, you ovulated. That would have been missed on Clear Blue.
uh, nice. So it really does step up the game, you might say.
Yeah, yeah, it
Well,
does.
I'd be interested, particularly since you're a Canadian researcher. Research in America is largely pharmaceutical company funded now,
Yeah.
more so, I think, than any time in our history. But why isn't the academic world just overflowing with research in reproductive hormones and these new technologies? Why not? If I were a much younger man, that's what I would be doing, I'm sure.
Yeah, that's a really good question, and I think what I would like to do over the course of my PhD studies is really start stepping up the approach to looking for grant funding,
Mm,
finding the language that is attractive to a secular audience to see that this is something that people want,
mhm.
and it's not just something that we want to ideologically drive because the NFP world is a small subset, but I think there's an interest and a demand for it. There's over 2,000 apps for the menstrual cycle out there. So there's a huge demand for menstrual cycle monitoring, right?
Wow.
And so if this is the case, let's capitalize on that and try to get into that market, that interest, and try to show them the goodness of monitoring the menstrual cycle for any type of intention. And I think that will require kind of shifting the language. NFP is a historical term that has been used for many years, but sometimes I'll use the term menstrual cycle monitoring or try to shift the terms. You know, you've probably heard of fertility awareness based methods
Sure, the
or FAM.
CDC likes to use that one. Yes.
Yeah, so there's all kinds of different terms, but these terms collect baggage over time. So I think we have to really think about language and how we can really be attractive to a secular audience so that we're not bogged down by biases that people might have.
And
Yeah,
Thomas,
that's
this
really
is a great
fascinating.
it is fascinating, and it's actually a great place to take a break here on Dr. Doctor before we come with more fascinating tidbits about natural family planning or menstrual cycle monitoring. Yes.
Well, welcome back to Dr. Doctor and our very special guest on this episode, Dr. Thomas Bouchard from our friends to the north in Canada. So, Thomas, what's the deal with progesterone? Why has progesterone sort of been the holy grail in the NFP world? What's the big deal?
Well, the biggest thing is identifying the when ovulation has occurred. So we talked about temperature before. So temperature shifts after ovulation. So that increase in temperature can be a nice way of saying yes, ovulation has happened. But temperature does come with some challenges. If there was a disturbance or an illness recently, then it's not valid. So progesterone is that test that allows us to ignore some of those circumstances that affect temperature because it's present in the urine. So progesterone tests are a way of confirming that ovulation has happened, and that way you can say that you've entered into the infertile phase after ovulation.
Now, in America, a progesterone test, a serum, a blood progesterone test is north of $100.
Yeah,
So maybe we should talk a little bit about cost. The Clear
yeah,
Blue versus the new monitor? What's
Yeah.
that look like for users?
Yeah. So Clear Blue costs about $200, and most of the other monitors on the market also cost about $200. I usually offer patients to write them a letter so they can put it on a health spending account
Mhm.
along with test sticks. Test sticks range anywhere from $1 to $3 to $4 each. And so you want to minimize as much as possible the cost of test sticks. So if people can keep it to maybe 10 to 15 test sticks a month, you're probably
Mhm.
looking at $40 to $50 per month,
Huh.
and hopefully with some health spending account that can offset the costs. But that is certainly a consideration, that the initial expense of the monitor, although those can last years, the monthly cost is there too. So the reality is that most people would make this investment. It's cheaper than a birth control pill, for example.
Sure, sure.
So I think people want to make that investment because they see the value there.
So
Now,
Tom, it's
how about the new progesterone inclusive monitor?
Yeah, so that one's also $200.
Um,
The Mira monitor is the test sticks are a bit more expensive. There's three other systems. One called UVA, which just measures LH and progesterone, and then there's another one called Anito that's now in the United States market, and there's another one, a system called Prove. The Anito and Mira monitors are ones that have a little device that you put a test stick into.
mm,
The Prove system is all test sticks, and they're line based. So you have to read the line, and there's an app to read the line. I would say the Prove tests, PROOV, those are the cheaper of all these options for testing. The Mira monitor has more data to back it up, and is the one that we published on last year.
So, Thomas, to be clear on price, women aren't going to be using this every single month. They're mainly going to be using it around the challenging times until their cycles are normal. Would that be fair to say?
That's a possibility. So I think what we need to find as physicians and healthcare providers to support couples is the method that works best for them.
Hmm.
And rather than trying to fit them into the method, say, what tools does this couple need to be successful and to achieve their goals? So sometimes that means, say, in the postpartum period, they use a fertility monitor to test their urine. Um, Maybe they get back into regular cycles. Their mucus is so obvious, and this happens. Lots of my patients will say, I went back to Creighton, or I went back to Billings because things were very clear, like clockwork.
just like
And I
before.
say, that's great, go for it. But then they might come back and say, you know what, things are not so obvious. So then we use another tool like the monitor, right? So you have to find the tools that are going to fit with the couple, not try to fit the couple into the method.
So, two times which I think are very challenging for women, I'd like you to address here. One, women undergoing chemotherapy, and two, um, women in that perimenopausal period just before their cycles stop. How can you help them?
Yeah, so chemotherapy is a brand new area of interest because prior to this, there was no option for women who were trying to figure out what's going on with their fertility during chemo and immediately post chemo. The reason for this is hormones, the hormones change in such a way that there's pituitary dysfunction from the chemotherapeutic agents, usually for, say, breast or ovarian cancer. And these hormonally active chemotherapeutic agents are not going to allow you to see any discernible thing in the urine, in the mucus, because of what we talked about with the postpartum period. The same thing will happen with the chemo med. Now, with the Clear Blue monitor, all you get is low, high, and peak. So you can't see any variability in what's happening with the estrogen or LH or, say, progesterone. We've had a few cases now that we looked at that who are on chemotherapy, and we were able to see a really elegant pattern where the pituitary dysfunction was so obvious with LH being sustained high. You don't see that in normal cycles. LH usually surges up really high when they have their ovulation, goes right back down. But this woman on chemotherapy had high LH consistently, very low estrogen consistently. When she came off the chemo, LH went down, estrogen went up, and she was able to ovulate. And so you couldn't find that without a quantitative monitor. This is the first time that it's ever been demonstrated in chemo that you could kind of identify fertility changes in the hormones with chemotherapy. So I did an interview with the organization Natural Womanhood, and they're a kind of a pro NFP group, and they were asking about how this would work and could other women be potentially use this. So we started a case series, and we're opening it up for people to kind of contact us, and we can guide them through the process. What was interesting is there was a couple in France who got in touch with me because she's on chemo and wanted to use this approach. The way she found out about it was that there was a monk at a monastery in southern France who read the Natural Womanhood article, and this I was so amazed to hear this. This monastery of monks support NFP users in southern France, and this monk came up to this couple and said, there's this doctor in Canada who has done something with chemotherapy. You should get in touch with him. So the grapevine is what it is. I got in touch with them, and I speak French, so I was able to help them, and they're now using this method during chemo. So it's actually a really nice opportunity to help couples through a very difficult time in their lives dealing with chemo and cancer, to still have that warmth of intimacy in their relationship,
Without the fear of an unintended pregnancy.
Exactly.
Yeah, that's
Well,
terrific.
Well, the other time is the perimenopausal. That's one of the two things Chris really wanted to learn in this episode. What help have you
Yeah.
got for that woman who's on the path to menopause, to
Because
giving
I'll
up the
tell you,
last egg?
in my practice, I think the postpartum breastfeeding couples are frustrated,
Yeah.
but the perimenopausal couples, it's not as funny. It's not as comical. They do not. They want to be open to life. At the same time, they do not intend to become pregnant at 48 or 49.
Yeah.
So let's talk about that group a bit.
Yeah. So that's also another case series that we're working on right now, following perimenopausal women through the different kind of straw criteria, the different stages of the premenopausal transition. And these transition phases, you can usually talk about variability in the menstrual cycle, but right now we don't have the actual hormone data to say what's happening during these variable periods that women are having. So the first thing that I'll tell women is usually the cycle lengths shorten, and then they start to lengthen and become more irregular, and then you start to drop periods. They become longer, much longer. And then eventually, over 12 months, you're going to not have any periods, and that's what we call menopause.
Sure.
So during that transition, that could be many years. What we want to show with these quantitative hormones is what's going on. It's likely that FSH starts to go up. Maybe it waxes and wanes a bit, and likely the pattern is as FSH wanes, estrogen goes up, and then as estrogen goes down, FSH goes up again. So there's going to be a unique pattern in the perimenopause that we'll be able to follow. And with likely a very low ovarian reserve in the 40s or late 40s, what we want to know is what are the thresholds we can recommend to women with these quantitative hormones to tell them this is a phase you can consider infertile. This is where you need to be worried about fertility, and you could be ovulating sometime soon so that you can catch it early. So it's that predictive value that we're looking for. Right now, we don't have the data to say, this is our plan, this is our protocol for these quantitative monitors in the perimenopause. That hopefully will come in the next year or so.
So listeners, if you're in that group, help is on the way. Stay tuned.
Yeah.
Are you
Another
recruiting
episode.
for that study?
Yeah, we are. Currently, we're doing it through uses of the Marquette method. They'll learn the Marquette method first, and then we would tell them how to get a mirror monitor. And using these test sticks, they'll be able to show their hormones in the urine, and then we'll retrospectively look at that data with the hopes of planning a later study, a larger study that is prospectively collected.
So if there's a listener who's perimenopausal and is interested in this, could they contact you?
Yeah, what I would suggest is they go through the website nfp.marquette.edu. So that's kind of the collector for anybody who's interested in the Marquette method. And if they get in touch with the nurses at Marquette, then we can get them started through that process.
So right now, what's the best you have to offer for women who are perimenopausal until this test strip data comes out?
So right now we do have a protocol for the perimenopause with the Clear Blue monitor,
Hmm?
and there's one published study on that topic. It's the only NFP study in the perimenopause that I'm aware of.
Wow.
So they can use the Clear Blue monitor, and they can use it for basically trying to track when it goes from low to high, and then they avoid pregnancy, and then they wait until they can find a peak, which is the sign of ovulation happening. So that particular protocol, they can still use the Marquette method for using the Clear Blue monitor. But what we'll have is way more detail and kind of a refined approach with the quantitative monitors.
Pause. Edit. Edit.
There's another fascinating study that you sent to us, and there were people concerned that COVID vaccinations might affect the menstrual cycle, and that spurred some interest in you. What happened with you there?
Yeah, so when I was in my family practice clinic, I had a lot of women coming to ask me about the vaccine and is this going to affect their menstrual cycles? This was a huge topic through the pandemic.
Sure.
So many people are asking me that question, and I thought, you know what, we have to study this issue. We have women all over North America collecting data, users of the Marquette method. So we decided to explore this with a retrospective survey where we decided to ask women to provide their chart data for us and tell us when they received the vaccine. And that allowed us to determine whether there were any menstrual cycle changes. We asked them for charts 3 months before they received the vaccine and 3 months after the vaccine to see whether we could find a change before or after. So this is called a repeated measures design. We use the woman as her own control. So her pre-vaccine data is her control for her post-vaccine data.
So it sounds like the strongest type of study you could do to get to that answer.
Yeah. So the downside with it is just the sample size. We had about just over 70 women participate. Um, if you look at other larger studies, there was a study with an app called Natural Cycles, and another study with the Apple Women's Health Group that's done through the Harvard scientists. They have massive data sets of cycles, and they have some a little bit of period data, but their main data is cycle length. So they were able to show in these very large studies, we're talking tens of thousands of people in both studies, that cycle length increased by about half a day. So that's not clinically meaningful. I don't know any woman who could say, oh, my cycle was half a day shorter or longer than last month. Nobody could tell that with that level of detail. So
Sure.
this is a type of statistical significance, but non-clinical significance in those studies. They didn't find any other changes. We also didn't find any changes either, but we didn't have the power in our study with a small sample size to detect that very tiny difference in cycle length. So
You know,
basically, we found no major difference in menstrual cycle.
it's interesting. It's at the risk of creating conspiracy theories we don't need anymore. But in my circles, in the obstetrical world, it sure feels like a few obstetrical complications that used to be not so common have become commonplace.
Yeah,
Postpartum hemorrhage and hypertensive disorders of pregnancy.
yeah,
I mean, anecdotally, we're all talking about this feels like it's orders of magnitude more prevalent than it used to be.
yeah.
I mean, it may be a decade or more, I guess, before we have the look back data to understand did infection during pregnancy cause something. But are you hearing any discussions of those topics?
Yeah. And we address this in the study, and there's a few things to consider.
Mhm.
One is confirmation bias.
Yeah,
So, confirmation bias is when you expect a certain thing and it comes true just because you want it to come true. So that's a major problem in kind of that retrospective look at things where
yeah.
you look back and you think it must have been this thing, especially because of the time course of when things happened. So confirmation bias was one of the biggest challenges with anecdotal reports. The other thing is isolating the variables. So when people say this or that thing happened to their period, it's not like we shouldn't believe them. It's that we can't attribute the change specifically to the vaccine. There's all kinds of other things that are happening in a woman or a family's life around the time of vaccine. They may be anxious about getting the vaccine. They may have had some side effects that worried them. There may be other things going on in their family. They're homeschooling. They brought their kids home from school, and had all the kids at home. Whatever the factors were involved, what we did with our study was isolate vaccine as the variable and say, even if there were changes subjectively or somebody looking back at the changes, those changes cannot be attributed based on our results to the
Sure.
vaccine itself. There may have been other disturbances, but the vaccine was not the disturbance that caused the problem.
One other question you wanted to address before we're done in about 3 minutes here. How can couples navigate between the various methods of NFP without it seeming like a turf war? Great question you propose we ask you.
Yeah, this is one of my pet peeves in the NFP world. It's such a small world that
Yes.
I really hate the infighting that can happen between methods. So I think we need to be what I would call NFP universalists, really allow the couple to guide our management and say, what is the right tool for this couple? What do they need in this moment? I don't want them to think the only way forward is the thing that I'm recommending. I want it to be right for them. So that's the first thing. And then we should also avoid arbitrary criticisms of other methods, thinking, I'm the Marquette guy, so I don't deal with anybody who does Creighton or something like that. The COVID study we did with the couple to couple league. So we combined data with Marquette and couple to couple league folks. That was a really nice opportunity to
Yes,
work
it was.
collaboratively. So when there are, scientific merits or criticisms for one method or another, I think we should be willing to be objective about those and honestly discuss them, but not do it in a way that puts down or kind of suggests there's only one approach and my approach is the best.
Mm. That's well said. It makes me think of some of the horrible fights I've seen in the pro-life community. Sort of a
Yeah.
big circle and everyone's shooting at each other when
Yeah.
we should all be on the same team.
Yeah.
That's really well said. Thank you.
So, Thomas, as we wrap up this episode, what do you want people to know and what sources of information would you recommend to them that they may not know about?
Well, I think there are lots of different organizations to turn to. There's the Institute of Natural Family Planning at Marquette. Dr. Marguerite Duanes has something called FACTS, where they train medical students to learn about NFP. The Couple to Couple League has just started the Fertility Science Institute. So all of these organizations deserve support, and they often operate on shoestring budgets. So anybody who has the funds to support these organizations should. And that's while we work on grants and mainstreaming some of this NFP research, we need to support them as well.
Well, Thomas, thank you so much for being a fan of Dr. Doctor. You came up and met Andy Mullally and me in Denver. We loved meeting you. And thank you for being an awesome guest. We hope that when you have more data to share from your research, you'll be back on the show.
You bet. I would love to.
More than that, we hope that we hear stories about you convincing 10 or 20 more people to become you.
That would be nice.
We certainly need a lot more NFP research. So God bless you and God bless you.
Thanks, guys. I appreciate it.
Welcome back to Dr. Doctor, and welcome to the answer to this episode's trivia question, which involves, what could it not involve? Cervical mucus. There's just nothing more interesting and exciting to me than that. And so, Tom, you posed a great question. Sometimes it's thick and stretchy, sometimes it's not. But what's the primary ingredient, so to speak, in cervical mucus?
And so, for those of you who thought about the makeup of the human body and guessed water, you're
Ah,
absolutely right. 90 to
well said.
95%. I mean, I guess it's like Jello, right? I mean, Jello's kind of thick, but it's over 95% water. I don't know how they do it. And there's all these things called glycoproteins and glycosylated proteins and mucins. And don't worry about it. It's mostly water. It's just these little extra additives that change.
You know, something I mentioned earlier in the episode about the fertile mucus at the time
Yes.
of ovulation lines up in these little tunnels.
Yes.
Um, and wouldn't you know, just by happenstance, that the tail of the sperm, or the flagella, they don't whip side to side like a shark's tail.
Oh,
They rotate in a circle.
oh,
And our friends in physics and hemodynamics and flow dynamics engineers will tell you that the most effective way to propel something through a tunnel is with a circular tail. Isn't that amazing?
it
It's
is.
hard. It's hard not to see the hand of our creator in that.
No, not at all. So, Chris, three top takeaways from Thomas.
Well, as usual, with a hard guest, it's hard to come up with only three things. I think he was really fascinating, and he does represent, I think, what we talked about in the intro, and that is the new NFP.
Right.
That is rigorous research driven with great science behind it. It's not your grandparents' NFP, but for the top three, I love that statement that he made about method wars, and that not every method is right for everyone. The
Right.
method should be driven by the couple and their special needs and their values. And I always like to say a couple picks an NFP method based on how motivated they are to avoid pregnancy or not. The second thing is that we talked about those two special categories, the perimenopausal years and those women who are undergoing or who have undergone chemotherapy. Really, I think the takeaway of that is help is on the way. It's coming. It's going to get better. And they're doing some really great work there. And then last, I think it'd be impossible not to mention the COVID corollary. And that is, their real study of real patients looking at kind of that urban legend that maybe COVID changed menstrual cycles. They've got pretty good data that says, actually, no, they weren't changed at all.
So thanks, Chris. Thank you, listeners, for being with us for another stunning episode, at least from our guest point of view. He was wonderful, of Dr. Doctor. If you want to listen to old episodes, you can find them, drdoctor.org. And you can go under episode archive and search over 290 episodes by guest or topic.
And we can come to you via video if you'd like. If you'll just look on our page on the YouTube link near the top of the page at drdoctor.org. Click on that and you can watch any episode that's available in video. We'd love to hear from you. If you have a question or a comment or an idea for an episode, click on Submit a Question. Let us know what you think.
This is Dr. Tom McGovern.
And this is Dr. Chris Stroud. We're signing off until your next dose of Dr. Doctor.